doing French too every night.
You're an achiever now.
We're just having fun.
Well, hey, I love it.
Just because we're doing it together. So because I want to learn. So she's helping me.
He's more helpful.
I don't know.
So I'm going to get up and start the intro here in just a second.
Have fun.
Yeah. Oh yeah. We'll turn over the stage.
So embarrassed this is
Oh.
at all.
No, this is perfect.
Okay, good.
Hey, this is
Honestly, we get, like I said, it's not uncommon not to have a big crowd at these,
Yeah.
but the repeat viewing of it just keeps going and going, and it always does very well.
Cool.
So, but it is awkward when you're here standing.
Well, it's less pressure that way.
But it's great practice too, and it's just
No heckling.
Well, I'm thinking that, and let's ask her.
You heckle me. I can take the heckling. All right, are you ready?
Yes.
Are you ready? Well, thank you for joining us tonight. My name is Heather Robideau, and I would like to officially welcome you to the Fayetteville Public Library. I would also like to take a moment to welcome our viewers watching the live stream from home. Before we get started, if you would, at the back of the room, we've got handouts and there are evaluation forms. We would love your thoughts on the programming that you would like to see here at the library. Your thoughts and comments on those forms really do help us plan programs into the future and into next year. So with that, I am delighted to welcome you to this discussion on hearing loss and cognitive decline. Studies have found an association between hearing loss and the development of dementia, but research suggests that early use of hearing aids may slow the development of cognitive problems. So on that front, joining us tonight is Jamie Turner, a PAC who has practiced in otolaryngology since 2015 with Dr. Cashman at ENT and Allergy Center in Fayetteville. She has spoken at numerous state and national PA educational conferences, and we are thrilled to have Jamie here with us tonight.
Can you hear me? Well, thank you. I'm excited to talk about hearing loss. I've been at the ENT and Allergy Center for about 10 years with Dr. Cashman and Haley Endicott, nurse practitioner. And the conversation about hearing loss has changed quite a bit over these 10 years, specifically in the last couple years now that new data has come out, and I'm excited to share it with you guys. So age-related hearing loss is the specific type of hearing loss I'm going to be talking about. It's very underdiagnosed because most of the time people don't come to us until it's a really big problem or until their family is tired of yelling at them, and then they come. It is associated with various socio-demographic features, so some people can't afford hearing aids. That puts a limit on treatment. And there are different health risks, including dementia and depression, cardiovascular health, falls. And there's just this lack of priority placed on treatment and identification of hearing loss. And I'm excited to kind of go through some of the data over the years and why all of a sudden is this more of a pressing topic. And I love this one because this is something my husband does. He just kind of smiles and hopes it wasn't a question. So like we all know, hearing loss gets worse as you get older, with up to 80% of functionally significant hearing loss happening in older patients. And so as you see here, once you're over 65, it's about a little less than half patients are going to have a significant impairment in their hearing loss. And when you're talking to people over 65, you don't always think that those patients or those people might have a significant hearing loss. And that's because we're designed to be resilient. We're designed to be adaptable and not show that we have this hearing loss and just kind of get through life. And so it's really important just to be cognizant of the fact that who you might be talking to might have a hearing loss and you might not even be aware of it. So I'm going to recap a little bit about anatomy and hearing. So sound comes into the ear and it goes down the ear canal and it hits the eardrum, which vibrates. And it stimulates these little ear bones here to work kind of like a piston and pump the fluid here in the cochlea, which triggers the little hair cells to vibrate. And then those vibrations of the hair cell in the cochlea are transduced into a nerve input to go to your brain. So when we're talking about hearing loss, it can occur on any one of these levels in the outer ear, in the middle ear, or even in the inner ear. And so if it's in the middle to outer, we usually call that a conductive hearing loss because something is blocking the conduction of those vibrations to the middle or the inner ear. Whereas with inner ear, this is all nerve hearing loss. So this is where we're going to be at for age-related hearing loss. So over time, the little hair cells inside the cochlea start to break and they can't transmit it into a nerve impulse. That's the type of hearing loss we're going to talk about. Because a lot of conductive types of hearing loss, whether it's wax or an eardrum problem with a perforation or scarring, or even these bones getting fixated or fluid in the middle ear from infections, all of those causes generally are reversible. Meaning that once you get past the hearing or the infections, usually the nerve is still intact and okay. And so this is kind of a recap of that. You can see for nerve type, it could be just aging, too many birthdays, and you start to have those nerves degenerate. It could be noise-induced damage, drug side effects, all kinds of issues there. Whereas conductive causes are usually kind of temporary and have to do with the blockage of that sound transmission. And you can have a mix of the two. And so what we really want to create is this idea that hearing loss is comparable to vision loss, this 20/20 rule. A lot of patients, when they come in, they're like, I'm missing 50% of my hearing. Which 50? Are you missing the high frequencies, the low frequencies, all the frequencies? It doesn't describe what we're dealing with. And so anything above 20 decibels is going to be a normal communication and normal hearing. When you start to fall below 20 decibels, you're going to have more severe, and then anything below 71 is they're having a very difficult time communicating at that level. And so this is kind of a picture of that. As you go down, the worse it is. And so anything above 20 decibels, this line right here is normal hearing. That's where most of communication happens. And so the way that we decide what the severity of your hearing loss is we look at what can you hear. And so we make little beeps, and then when you hear the beep, you get a little asterisk there. So in this higher pitch, this person has a mild loss. But as you get into the really high pitch, they've got a moderate to severe loss. And so that's why just saying I've lost 50% of my hearing isn't very helpful to patients. So here's two different hearing tests. And what I want you to take away here is that with age-related hearing loss, we're going to have this downward sloping pattern. Across the top, we've got pitch. This is high pitch, like a little girl voice, versus low pitch, like a deep man voice over here. And then volume down this side, so really loud down here, really quiet up here. And in age-related hearing loss, you're going to have loss of these higher frequencies first, and you're going to have more preservation of these low pitches. And if you look at the bananagram of where most of communication happens, these high pitches are just a few specific sounds. So like TH and F, the difference between death and deaf, the th and the f. Those are sometimes hard for patients that have high frequency hearing loss. So if you don't hear the word deaf in the context of a sentence or watch their lips move, you might be thinking they're saying death. And so what ends up happening is the brain is filling in the blanks. It's getting some of the communication, and it's just having to piece together the information. And later in some of these studies, we're going to see how this creates what we call cognitive overload. The brain is working really hard behind the scenes. People don't realize when they have hearing loss how much their brain is overworking. We're going to see that later in another study where they did functional MRI, and they actually watched how the brain lit up in patients that had hearing loss versus no hearing loss. And so I really like this communication bananagram because it helps people understand why are they able to hear some things and not other things as well. And then as age progresses, this is kind of just a general progression. You can see that those low frequencies just stay kind of preserved. And so yelling or raising our voice to communicate isn't a good strategy because it's still the same syllables that we're missing. And that's why we encourage when someone's having trouble hearing what you're saying to try to rephrase it, because oftentimes whatever you're saying is in a pitch that they can't understand. And you can see that here, like this versus that, taste versus flavor. And so you got to be a little creative when you're communicating with patients that are having hearing loss. And if they don't get it the first time, try to rephrase it. So why is this so important? And it's because of our aging population. The baby boomers are getting older. We're about to jump from 44 million in 2020 to 73 million by 2060. That's a lot of aging adults. And most of them are going to be over 60. And we learned earlier that once you're over the age of 60, about half of these patients have a functional problem with their hearing, like it's impacting their communication with others. And so this is just talking about hearing loss, not to mention that if you have hearing loss, the risk of dementia goes up. So it's going to be interesting to see the projections of dementia over the next 20 years as well. So we're going to kind of talk about what ways does hearing loss affect the brain, and we're going to go through some different studies that have been done over the decade that kind of give us an idea of how it's affecting the brain. One is through stress, and I've felt this, I'm sure everybody has felt this, when you're trying to communicate with someone and you can't quite get what they're saying. And I don't even have hearing loss, but we were on a cruise recently and they were talking on the intercom, and I was pretty stressed feeling because it was instructions that I needed. It can also create this cognitive impairment because the greater the workload of the brain is used, the more fatigue your brain is going to have. So if your brain is really trying to listen all day, by the end of the day, you're going to have listening fatigue. And so you're going to have this cognitive impairment that goes with that. It also contributes to isolation and loneliness. Isolation is well documented to cause atrophy in the brain and to trigger things like dementia. Anxiety, and so patients will start to avoid situations where they know that they may not communicate well, like family functions. There's too many people around, too much background noise, they can't hear their grandchildren, all of these excuses. And then finally, depression. There's quite a bit of literature that's showing the link between depression and hearing loss, and how the depressive scores can improve after the use of a hearing aid. And so this kind of just reiterates that. We've got cognitive load, we've got changes in the brain structure, and then that last theory is social isolation. So we don't really know exactly how the brain is affected by hearing loss, but these are kind of the three overarching theories that are out there from researchers. And so this is kind of another look at that. And it's this cascade hypothesis where multiple influences are affecting the brain. And so with hearing loss, you're going to have that decreased auditory input, and so the nerve isn't working as well, which causes a structural change in the brain, and then you get that atrophy or that loss of volume of the brain. It's kind of the if you don't use it, you lose it theory. And then also there's, you're having this verbal communication failure. It's a lot of effort on the listener to be involved in communicating, and so they just give up. They have that decreased socialization. And this happens over a slow period of time, and oftentimes patients are unaware that they're even having this problem, and then they end up with the depression, the anxiety, and that social isolation because it's just too much effort. Now, when I first started practicing 10 years ago, there were lots of studies out that talked about hearing loss and cognitive issues. And the problem with all of these studies is they were either underpowered, meaning that they didn't have enough participants in the study to really make it a valid study, or there was bias to the study, meaning that it was not weighted correctly. So if someone is in hearing aids, it's often because they have money for it. And that creates this bias when we're looking at the research data. So there was never really a great randomized controlled study, which is the gold standard for studies. There's lots of different types of studies like observational or longitudinal. And so this isn't something new. It's something we've seen for a long time. We just didn't have a good study to prove it. We're going to talk about a good study towards the end, and that's why I'm here to talk about today. So this is the first study that I really like. It was done back when I was 9, and they looked at people for 11 years that had hearing loss. And what's really important about this study is it provided a rate of decay. It told us how quickly do things go south when you have hearing loss. And we're going to kind of reference this study again later. And they found that you had a 40% faster decline in cognition over a 6-year period compared to people that had normal hearing loss. Now, the takeaway point here is that if you have hearing loss, on average, it takes about 7.7 years to decline by 5 points. So 5 points is kind of what's significant on this 3MS scale. Now, the 3MS scale is a widely used test for cognition. And so what they found is that if you had normal hearing, it took a lot longer, almost 11 years, to see any change in this global cognition score here. And so later, when we're talking about the ACHIEVE study, we're going to go, well, why does it look like hearing aids don't help? And it's because of this rate of decline. We're going to talk about that again. Now, in 2011, Johns Hopkins, they studied 639 adults for 12 years. And what I really like about this is people want to know what is their specific risk. And what they found is that if you had mild hearing loss, you almost had a double of the risk for dementia. And if you had a moderate hearing loss, you were at more than 3 times risk for someone that didn't have hearing loss, and then 5 times more likely if you had severe hearing loss. And so while hearing loss is mild and you may not want hearing aids, it's important to realize the associated risk that goes along with that. Now, I really like this study because I'm like, who paid for this? Because that is a lot of people over a long period of time. So 38,000 people over 17 years. The patients that had hearing loss when they entered the study had almost a 79% increased risk of developing dementia at some point over that study period after they adjusted for other health risks and age. So that kind of just reiterates the point that the longer that you have that hearing loss, the greater your risk of dementia is at some point in your life. And that's just a lot of people. It's pretty incredible they did a study that big. Now, using hearing aids or cochlear implant to restore hearing doesn't just have the positive benefits of being able to hear. We've also seen it in multiple studies where that neuropsychiatric status improves, less dementia, better global cognition, better at memory tasks, and just being more socially functional because they're plugged back in. And I really like the concept of plugging the brain in. It's important to hear things like the air conditioner kick on or the trash truck outside. And so while someone might be at home alone most of the time and not communicating with others, having that brain auditory stimulation is really important for just the neurocircuits of our brain. Now, I really like this study because I'm very visual. And in this study, they did functional MRIs on patients who had hearing loss and didn't have hearing loss. What they found is that your brain, through neuroplasticity, or the ability to kind of like learn new tricks, will recruit other areas of the brain used for visual or smell and kind of get the part of the brain to listen. And so you can see those images in the pre-hearing aid group. It extended through the temporal cortex when really it should be going kind of more back and behind. What they found is that if they treated someone with hearing aids for just 6 months, they understood speech better in background noise. Now, I hear a lot of patients say, well, my hearing aids don't work all that well when there's a lot of background noise. It's not a perfect world, but I bet you're hearing better in background noise with the hearing aid than if you weren't. And also, they had faster processing speeds, better working memory, and just overall increased cognitive function. And those changes where it was lighting up had reversed after they had been wearing the hearing aids for 6 months. And so this is kind of a recap. It's basically talking about how your brain is recruiting and that those other senses start to compensate for that loss. But that's not really a good thing because you need those areas of the brain to do their job. And so that overall load on the brain in an aging adult may be part of why they aren't adapting as well. So that brings me to the 2020 Lancet Commission on Dementia Prevention, Intervention, and Care. This came out in 2020. They identified 12 potentially modifiable risk factors. I have a handout that goes through a lot of these. You know, physical inactivity, if you don't use it, you lose it. Smoking, excessive alcohol use, air pollution, head injury, less education in early life. And so those lifelong learners, all the people here today, congratulations, you're keeping your brain stimulated. Hypertension, diabetes, depression, hearing loss, obesity, and then infrequent social contact could all increase your risk for dementia. And so it kind of goes through those here. And what they found is that up to 40% of dementia cases can be prevented, that they have modifiable risk factors. And so what they found is that hearing loss is actually the strongest modifiable risk factor for dementia. And I need to update this slide. It's actually 7% now because just in the past 3 months they have updated this to add visual loss here. And so we went from having 9% to now 7% for hearing loss, but it's still one of the highest modifiable risk factors that there are for dementia. And so the commission based their information off of a study called the ACHIEVE study. And the reason that this study is so important is because it's the only randomized controlled study where they randomly assigned people to a treatment group versus a non-treatment group and then looked at the outcome. And they found that hearing intervention slowed down loss of thinking and memory by up to 48% over 3 years. That's pretty significant. And so in this study, they would randomly assign a person to either a hearing intervention where they got counseling about how to hear well and they got hearing aids, or they were put in a health education control group. So this is the non-treatment control group, and they basically just gave them random information on lots of different health topics, nothing specific to hearing. And then they tested their hearing intervention at 3 years on a global cognition scale. And they had a big group of participants, 977, and they were recruited from 4 different areas of the country. The inclusion criteria was age, so 70 to 84. They did not have treated hearing loss, and at the entry to study, they had normal cognition on testing. And so this kind of just goes through, you know, how they got people enrolled, and then how they did the follow-up visits and the testing. Now, when I first started looking at this study, I was like, but wait, the results say that there wasn't an improvement with hearing aids. But you really got to digest this and look at those results a little bit deeper. And so they had 238 people that were from a heart health study. So they were already enrolled in this other study, and they decided to tack on this hearing intervention part. On average, those patients had higher risk factors for cognitive decline, hypertension, heart disease, smoking, these types of things. And then they had 739 people that were just healthy community volunteers that had hearing loss, but no change in cognition. Now, if you look at both groups together, they found that hearing loss, they found that hearing aids weren't helpful. But if you separate out the 2 groups, they found that the hearing intervention greatly benefited those heart-healthy patients and reduced their cognition by 48% over 3 years, whereas it didn't have any effect on the healthy people. And so let's think back to that earlier study where we found that healthy people on average take almost 11 years to show any decline on that study. Whereas if you have risk factors, you decline a whole lot quicker than if you were healthy. And so this slide talks about that we didn't have a long enough study to see the hearing aids affect all patients. So, healthy patients that have hearing loss still benefit from hearing aids. It's just, you gotta have a much longer study period to be able to see that change. So why is it important to treat hearing loss? Because it is one of the modifiable risk factors for dementia, and it can get people plugged back in. But really only less than 20% of patients actually get hearing aids that could benefit from this. So it's a very untapped potential to help people connect to others and to prevent dementia. And I just really found this interesting that pet health was more important over hearing health to most people. I think I'd probably fall in that category. And that a lot of people don't know what is normal hearing. And so just this lack of education about the importance of hearing loss. And so there's a big push to create access to hearing aids, because most people that get hearing aids are people that can afford them, because Medicare does not cover hearing aids. And in 2022, the FDA put out over-the-counter hearing aids. Now before that, they were just amplifiers. They amplified all sound, whereas now the over-the-counter hearing aids can kind of be a little more customizable and produce the sound a little bit differently. There are a lot of different brands over the counter. The big drawback to these is you don't have someone there helping you through that process, and you don't have someone there making sure that you're a good candidate for an over-the-counter hearing aid. Mild to maybe moderate hearing loss is what it's been instructed for. But there are lots of caveats to that. Is it going to fit well? Do you have other problems like eardrum problems or ear canal problems? And so, meeting with a physician or at our clinic to get an evaluation before you invest a lot of money is a good idea. So besides just hearing aids, how can we improve our communication with others? Well, minimizing background noise is definitely important. Using face-to-face communication, I always like to tell people, you don't play catch with a ball around a corner. You don't play catch from upstairs, from one bedroom to another bedroom, and so you shouldn't be communicating to people around corners or upstairs or downstairs, because they're just not going to hear you. And then rephrasing things so that you're not just saying it louder, because that's not very helpful. And then summarizing what you've heard or what you've said to make sure that the patient or the person is understanding and comprehending what you said, just to kind of make sure you're on the same page. There are a lot of negative experiences that we hear with hearing aids. I really love this study here because it talks about the power of a positive listening experience. And so not just focusing on, well, every time I wear them in a restaurant, I can't hear. Well, that's how often do you go out to eat? And really focusing on how has it helped you communicate and trying to stay positive. There's lots of different reasons why people may not like their hearing aid. They may get too much wax. That's when getting your ears cleaned is helpful. Having them properly adjusted by an audiologist to make sure there's not too much static or noise. I think the cosmetic concern is less now because they're pretty discreet, pretty small. You can't really see them. There is a hassle factor. You do have to maintain the batteries. You have to clean them. And so a hearing aid may not be the best option for everybody, but making sure that you have, someone qualified to walk you through that process is a game changer in a lot of instances. There is also the CapTel phone. If you don't wear a hearing aid and you're just having trouble communicating with others, Arkansas does have a program where you can get one of these phones to help you interact with doctor's visits and making appointments and things like that. And then there's also the voice carryover, which Arkansas has available for patients as a resource. But really, the future of hearing loss treatment is kind of up in the air. There's lots of studies being done, but for right now, the treatment is hearing aids. And we know that they work to help reduce cognitive decline. And so hopefully in the future there's another option for that. And then there's my resources. Any questions?
Yes.
Yeah.
So that bananagram,
Yes.
is there a way that I can access that? Like something I can put in to my phone right now so that I can look that up and study it a little better? The audiogram of familiar sounds, perhaps that's what I should.
Yeah, I can get you a copy of it probably.
Oh, okay, cool.
Yeah. Yeah, it's interesting how most of speech kind of happens in this middle range here. And so different words can sound more difficult. I do want to point out that I didn't talk about this, but when we talk about hearing loss, you can have a volume issue, but you can also have a clarity issue. And we didn't list that down here, but basically with clarity, we turn the volume up to where we know you need it. So if we were looking at this middle line, we'd probably turn it up to around 60-ish. And then we give you a specific set of words that are kind of confusing. And we see what percentage of the words do you get correct. And that looks at a little bit different part of hearing. It looks at how the ear transmits to the brain. And so some people, they can have a diagram that looks like this, and you're like, hearing aids. But then when you test their DSCRIM score may be worse. It may be like 40%. So that basically means that if I put a hearing aid in that person, they're only going to hear about 40% of what we give them, because that's with the volume turned up. And so that's why with meeting with an audiologist to really talk about your hearing loss and making sure it's a good fit for a hearing aid is important, because there's a lot that goes into the hearing test. And so we can kind of predict how well you should hear with hearing aids based on the full test. Any other questions? All right. Well, thank you.